So, as initially, I would like to thank Imad and his organizing committee for the invitation. So, as we start, the scientific committee raised that questions. So, I was planning for your actually participation, but unfortunately, we cannot answer this barcode because I'm not using my computer anymore. So, next. So, the epidemiology of adenocarcinoma is no more statics. So we know that disease historically, in the historical context, it's increased up to 7-fold in the Western country, but the new global, as mentioned, we have some like a pandemic covering all the globes. And the more driver for this is the two major risk factor, obesity and reflux. So if we are looking to the globe map, you can see the different incidence of this cancer all over the globe. Also, there is some area still with low incidence, but you can see a geographical disparities. So the most epicenter for highest incident in the East Asia, especially in the China and some part of Africa. And to be able us for set a criteria for any screening test, we have to be aware about epidemiology. Because if we are planning to design a screening program, we should be familiar with which subtype of cancer in that area. Again, the mortality all over the globe is high, and looking for the association for those population has been proposed by the questions. So there is a lot of evidence supporting the association between gastroesophageal reflux and the prevalence of Barrett's esophagus and gastroesophageal. This is a recent systemic meta-analysis showing that the incidence of Barrett's in a GERD population up to 7%, and the adenocarcinoma was 0.6. And if we make it a population-based, the Barrett's incidence, it's reached up to 10%. Another study looking for association between the Barrett's esophagus and gastroesophageal cancer. This is a large national cohort study from Norway. They found that 5 milligram increment in the PMI, it's associated with the hazard ratio of 1.34 for esophageal adenocarcinoma in men and 1.28 in a woman. So we have a population and they are at a risk from this disease. So the pathogenesis well known for all of us. The mechanistic link is clear. The central adiposity from the obesity is the main driver for GERD. The chronic reflux will lead for a Barrett's. Metaplasia, the only known precursor for adenocarcinoma. This linear progression in the pathophysiology gives us a critical window and opportunity for screening and intervention. So the rationale behind the screening is that we are dealing with a very poor survival cancer with survival rate less than 20. So the early detection is everything we have. It's our strongest weapon to fight this cancer. And we have a very effective treatment for that precursor. Endoscopic eradication therapy, as mentioned by Dr. Mariam, is a very highly effective, safe, and can prevent cancer. So our opportunity is to identify patients with Barrett's, allowing for their surveillance and the timely endoscopic eradication therapy. So the argument of screening is built actually in the foundation of necessity. We have a very fatal cancer, we know one precursor, and we have very effective treatment for that precursor. There is a multiple society guidelines. They put their guidelines. They are almost the same with minor differences. And all the guidelines advise for screening only in high-risk population, which is usually chronic gastroesophageal reflux disease, male, white, obesity, and family history with a smoking. We have different tools to screen: invasive, including the regular gastroscopy, transnasal, although there is some concern about the size of the biopsy can be obtained. And we have non-invasive devices, including cytosponge and EsoCap, EsoCheck, and the capsule endoscopy. And still the data from the evidence is controversial regarding using it in screening. Just overview of our tools. The gastroscopy is still the standard with a limitation. It's an invasive, needs sedation, very expensive, and it's operator dependent, and usually required pathologist to review the biopsy result, which is not easy always the times. So the AI came to solve this issue with this study showing that adequacy of predicting endoscopic imaging histological operates with accuracy, sensitivity, and specificity more than 94%. Then the cytosponge, which is the most studied non-endoscopic device, has been proven by multiple studies its effectiveness. The advantage, it's a minimal invasive, doesn't require training to achieve competence. It's more cost effective than endoscopically, but it still has a limitation that the pan-esophageal sampling may miss the focal intestinal metaplasia. And again, it's used as a triage test. So it's a need endoscopy follow-on to confirm the finding. The important question before setting any screening program is the cost effectiveness. So does our tools running in our population will be cost effective? So this is a very nice comparative cost analysis looking for the performance of endoscopic screening. So only endoscopic screening and esophageal cancer. And they're able to conduct it in 3 independent simulation models. For each, the combination of 6 rays and the number of repeating endoscopy, either one or repeated times. And they found that screening with endoscopically only cost effective in high risk population, which is usually male, white with chronic reflux and above 50. So using endoscopic screening in low preference Barrett's esophagus population is not cost effective. Again, another study just recently came. They comparative cost effective in based GERD on and without GERD as a strategy. They make 3 scenarios and using multiple endoscopic intervention, including gastroscopy and non-invasive tests, and they found again the cytosponge only effective in high risk population, and it's the favorable strategy for non-diagnostic. So the pyramids actually illustrate the dilemma of the screening. We consider massive screening efforts for targeting a broad base only to identify a small fraction of patients with Barrett's. And even a smaller fraction, they will develop cancer. So the risk of overdiagnosis and significant resources burden are real crucial in this pyramid. So instead of wide population screening for all patients, we should get a module risk prediction algorithm that helps us to identify at least a patient at risk, which we can run in them an invasive test. And if they tend to be normal, we can. If they tend to be at a higher risk, we can deploy our gold standard and put them in the standard endoscopy, which is most likely will yield the result in this population. So my answer for the question is not yet actually, but we should be prepared. And the no is qualified for that. The population-wide screening is non-endemic area is not currently justified. The uptake is a major barrier, and all of us may be aware about the British trial for Barrett's esophagus when they invite more than 10,000 patients for a gastroscopy screening, and only 25% of those invited accept the invitation. the cost effectiveness is still unproven. But we should abandon one-size-fits-all approach. We must validate the risk prediction models for non-endemic area, and we should invest and integrate a non-invasive test, and we must target screening in high-risk individuals only. At that, I would like to conclude, and thank you.
Thank you very much, Dr. Nawaf. So we'll open the floor for questions. So I have a question for you, Dr. Nawaf. So as you mentioned, esophageal adenocarcinoma is a problem worldwide. In our region, we do have high prevalence of obesity, high prevalence of reflux, which are risk factors for adenocarcinoma, Barrett esophagus. But maybe we're not seeing as much Barrett's as the Western world. Are we missing it? Are we not seeing this? Barrett esophagus, is the pathophysiology might be different. And in terms of the screening, do you think we should focus on, should we offer screening in our region specifically? Should we focus on high-risk group, such as patient with sleeve gastrectomy, for example? So what are your thoughts in terms of the screening in our population?
So, as we know, the association is there between the obesity and the gastroesophageal reflux with the Barrett's. But in all what we have modules around the globe, only high-risk patients, they should be screened. So instead of doing a mass screening in a very broad base, we should stratify that screening. So make it a smarter screening pathway for the patient with chronic gastroesophageal reflux, obesity, and above 50. And you can start with an invasive test, which is using cytosponge or the ESOCheck. And if you have this positive patient, you can enroll them in surveillance after this.
Dr. Noah, thank you for the presentation. So just the questions. So still we didn't have, it's not common parrots in our area. So is it cost effective to have a lot of advanced technology to screen, or gastroscopy is enough for high risk patients? Because this is what we have. So I think we have only 2 or 3 studies in our country. So still the prevalence is very, very, very low. So I think it's cost effective not to be applying all the sophisticated or all the advanced technology to screen, while we have a gastroscopy can be done now with every center. And I'm not sure, is still gastroscopy is invasive?
Yeah, it's still required the indication. Also, the complication from this procedure is very, very unlikely, but still considered as invasive. So it's carry risk regardless of this risk if small or no. For the cost effectiveness, no. All the studies showing that if you run a screening program for Barrett's in low prevalence population, it will be cost sensitive. So usually we are advised against screening in low prevalence population.
Thank you, Nawaf, for a nice talk. I echo what you say in terms of not needing screening. I think even though commenting on Ali's question, are we missing it? The end result is cancer. And we know from the national registry, at least in this GCC region, that esophageal cancer is the least luminal GI cancer we have. So we have colon number 1, probably stomach is the second, pancreas, and then perhaps esophageal. So I don't think at the moment we are ready to look into that. Now, stomach, I think, is more important. But perhaps if we're going to screen, as you said, maybe a risk modeling where we assess those high-risk patients, family history, smokers, obesity, with some changes and, chronic esophagitis, and perhaps having a dual screening where at least if you're doing an upper, you can screen the esophagus and the stomach. Maybe that's something can be considered. But again, at the end, it has to be very risk stratified. But I don't think we're ready for widespread screening. Thank you.
Last question, Dr. Hamad.
So Nawaf, back to Mariam question. So if we have, she commented on that. If I have dysplastic esophagus or low-grade dysplasia, and the patient on maximum PPI, do you advise for fundoplication? Is that curable?
So in dysplastic pellets, you have to apply eradication therapy, either using a PPI.
We use the PPI and it's not responding. So you go for fundoplication?
So I would advise for eradication therapy, which is fundoplication can be considered one of them.
And it will revert? Do you have any data? It will revert the dysplasia?
We have data about the pediatric intervention and the fundoplication. It can do a good result in terms of eradication pellets post.
Okay, thank you very much. Thank you, Dr. Nawaf.